Good evening once again. Today we'll be looking at a very important topic in the intensive care unit. And today we'll be looking at smart ventilation. All right, it's an acronym that a friend and I, coined to look at mechanical ventilation in a special way. So we'll be discussing what we call smart ventilation this evening. I just want you to just sit back and enjoy the lecture, and hope that we'll find it very enlightening. All right, so a mechanical ventilator. I'm looking at our learning objective. Okay, let me just start here. So our outline and learning objectives. We're going to be looking at the introduction. We'll look at the characteristics of an ideal mechanical ventilator, indications for mechanical ventilation. Then we'll look at the SMART acronym for mechanical ventilation. We'll look at some clinical scenarios as we go on. So by way of an introduction, a mechanical ventilator or a mechanical ventilation is any method of breathing assistance in which the ventilator supports a patient's breathing. This could be partial or complete support. All right, when the machine takes over the bulk flow requirement of the patient, that ventilator is taking over the breathing requirement for the patient. But when the ventilator assists the patient, so that is what we know as partial support. Now, mechanical ventilatory support is among the commonest indications for admission to the ICU. We did a study sometimes in 2017, all right, which was published in the Nigerian Journal of Anesthesia and Clinical Research, or Journal of Anesthesia and Clinical Research, where we found out that in a tertiary hospital in Nigeria, about 34.4% of all admitted patients to the ICU were mechanically ventilated, and that is a huge number. The average duration of mechanical ventilation in our study was about 12 plus or minus 10 days, and patients who were mechanically ventilated had about 4 times the chance of death when compared to not ventilated patients. So mechanical ventilation is a topical issue in the ICU, and that's why it's good for us to spend some time to look at this very useful therapy in the ICU. All right, so quickly, let's look at 3 or 4 scenarios as we continue. All right, I want you to just think about these clinical scenarios as we discuss smart ventilation today. So the first clinical scenario we're looking at is a 42-year-old male patient. These are real life cases. All right, a 42-year-old male patient who is admitted to ICU for ventilatory support due to community acquired pneumonia. His arterial blood gas results are as follows: pH is 7.32, PaO2 is 80 at FiO2 of 100, PaCO2 is 45, and bicarbonate is it's 26, not 46. That's a mistake. It's 26. So anybody want to try this before we go on? Let's have the basis of what you already know. All right. So what is your respiratory diagnosis based on this result? And what are your initial ventilator settings for this patient? Yes, I can see that Dr. Lauye. So try and let's see what you think about this scenario that we just presented.
Yes, good evening, Prof. Good evening, ladies and gentlemen. The patient has respiratory acidosis, and for this patient, we want to put the patient on mechanical ventilator. We want to hyperventilate the patient so that the patient can lose some CO2. Though the CO2 uh, is at the extreme of high value because the PCO2 is 45. Ideally, it's supposed to be between 35 and 45, but it's on the high value. So the FiO2 is still good at 100 as it is, but the respiratory rate should be increased. And probably the PEEP for this patient too should be a little bit high so that it will make a time for uh, ventilation, perfusion stuff, sir. Thank you, sir.
Thank you, Dr. Loy. Anybody with a different opinion? There should be, I expect, different opinions because I do not agree perfectly with Dr. Loy. All right. So, agree? Go ahead, take a shot at this. Anybody? I thought someone was. Any other person wants to take a go at this clinical scenario? I'm sure we must have managed a patient or two like this. Don't go quiet on me now, class. Should I mention name?
Okay, sir. My opinion is almost same with him. With respiratory acidosis, that is slightly compensating.
Yeah, but let's look
Okay,
at this.
the bicarbonate is changing.
Let's look at this. Look at this
Okay.
question.
Okay, Prof.
This patient has community-acquired pneumonia, needing ventilatory support. What do you think? Do you think is the respiratory acidosis that is a problem here? I don't
Sorry,
think
Prof.
so.
Prof, I think his problem is oxygenation as well.
Beautiful. Who is that? Who is talking?
Sabina.
Sabina. Yes. Go ahead, Sabina. Yes,
Yes.
you're on the right track.
So,
Oxygenation. Tell me.
with an FiO2 of 100%, his oxygen should be like 3 times. We should be
PaO2, you
expecting
mean
a
the
PaO2.
partial
Yes,
pressure of
yes,
oxygen? Yes.
should
Go
be
ahead.
higher than that. We
Yes.
should be expecting like 240 or so, around that, I think.
Yeah. Yes,
So
I
we have
agree with you,
problem with oxygen.
Sabina. Yes. So the major problem here is hypoxemia. So this patient is in type 1 respiratory failure.
Respiratory failure, yes.
Yes, with respiratory acidosis. But the most important thing here is this patient is in the type 1 respiratory failure, hypoxic respiratory failure. All right. So what we do, we calculate the PF ratio. All right. If you look at 80 over 100, that is very, very low. So the oxygenation is a problem here. All right. So, Sabina, what will be your ventilator setting for this patient?
Okay. So, I'll I'll give, okay. Will I go volume control?
We lost you. We can't hear you. Anybody want to add Sabina until the volume comes back? Hello, is it my network? Can you hear me?
Yes, sir. We can hear you, sir.
You can hear you, sir.
Okay, so we lost Sabina. Anybody wants to try? So the idea here is you want to improve oxygenation, all right? And as we go on, we're going to be looking at how to do that with your ventilator. Okay, let's look at the second one. All right, a 29-year-old female asthmatic patient requiring respiratory support due to status asthmaticus. ABG results show severe hypoxemia and hypercarbia. She also has altered mental status with a GCS of 8/15. Anyone? Discuss your management plan specific to our ventilatory assistance here. And number two, enumerate other adjuvant therapies that may help this patient in the ICU. It's a tutorial, so let's try. Anybody? Anyone? Everybody's quiet on me now.
Hello, sir.
Yes, Ololade Tawoshe.
Yes, sir. Yeah, a diagnosis of a type 2 respiratory failure made in this patient because he has both hypoxemia and hypercarbia. So, and most likely responsible for the GCS of 8/15 due to narcosis and carbon dioxide narcosis.
Beautiful.
So for the
Yes, go ahead.
management, we want to place on ventilatory support. I want to give a tidal volume of 5 to 6 to 8 mils per kg, usually within the range of 450 to 500 mils. And then I want to place on SIMV mode of ventilation, and then increase the respiratory rate and give a respiratory rate of so that there will be a form of hyperventilation to wash out the carbon dioxide. And then the FL2 to be 1.0 or 1.0 initially before I now start reducing it gradually. Then, hello?
Yeah, I can hear you. I'm here.
Okay, sir. So for other adjuvant therapies that may help this patient, being an asthmatic patient, we can nebulize the patient with salbutamol, alternate with normal saline, and then status asthmaticus also requires respiratory support. Yes,
Yeah,
we
good
can.
try.
Yes,
Good idea.
also, thank you, sir.
Good idea. Here, remember that this patient has severe hypoxemia hypercarbia, so it's a mixed type of respiratory failure. All right, you know we have three types: hypoxemia type 1, hypercarbia type 2. When you have both, we call it type 3. So it's a mixed picture, and we're going to be looking at it as we move on. There are specific ventilatory strategies for COPD and asthmatic patient. All right. Good try. Let's see. Okay, I see some chart. For the asthmatic increased respiratory time. Yes, we're going to be going to that. Good. All right. So you want to give more time for expiration. Good. Zeno Gloria, your comment noted. Okay, so let's see the third clinical scenario. A 23-year-old parturient, gravida 3, para 2 plus 1, had emergency cesarean section under subarachnoid block. She was noticed to have had an arterial desaturation or SpO2 of 85% on oxygen-enriched air. Her level of consciousness began to drop and was producing some foamy secretions from the mouth. What are your likely differentials? How will you manage this patient regarding her ventilatory status? Yes, so the tutorial today is taking a different turn. We're discussing clinical scenario first. Anybody? These are live cases, all right? So these are live cases, and you are the senior registrar or the registrar on call, and you are called for this patient. How will you manage this patient? Anybody? Dr. Ikabod?
Hi, Prof. How are you?
I'm good. How are you?
I'm good, thanks. With such brief history, probably I'm thinking this patient may have pulmonary edema.
Yeah. What in this
Mm,
history, what in this history or in this presentation refer to pulmonary edema and how? You are right. I agree with you. Pulmonary edema, most likely, that will be number one on the list. Go ahead, sir.
yes, because of the low oxygen saturation and the foamy secretions from the mouth.
Good. Okay. Go ahead.
Mhm. So in terms of how you manage the patient on the ventilator, I will increase the post-event expiratory pressure. The tidal volumes I would give 6 to 8 mils per kg. Also set the respiratory rate. In terms of the respiratory rate, I'll ensure that she has a optimal respiratory rate, maybe 12 to 20 breaths per minute. And my IE ratio would be 1 to 3. And FiO2, I would increase it probably to 100%.
Sorry, does they come
And
out? Sorry for stopping. Why do you want to do IE ratio 1 to 3? Why?
I would want to increase the expiratory time so that she watch. I'm not sure how bad her ABG is, so I would want to. Sorry. On the second thought, I think I'll put it at 1 to 2, not 1 to 3.
Yeah,
Apologies on
1
that.
to 2. You can
Yeah.
even do inverse ratio ventilation here to improve
Yes.
oxygenation because SpO2 is 85 and on
Yes.
oxygen enriched air, not on room air. It's on oxygen air. So SpO2 on room air will be lower than this, isn't it?
Yes, indeed. Yeah.
So you want to increase inspiratory time. I will do in fact in this patient inverse ratio ventilation will be appropriate. Don't you think so?
Yeah. Certain. Certain. I agree.
Great. Good try. Good job, Dr. Ekabo. Let's look at the last one. I think should be the last one. Then we'll go for the lectures. Okay. Sorry. This is the last one. All right. So at the end of it, we will look at some of these things we've mentioned, and we'll look at where we can improve our practice. So smart ventilation, by introduction, the mechanical ventilator can be a life-saving device if we use it smartly, or it can be a dead boss if we're not familiar with how to use it. Those clinical scenarios we mentioned, wrong usage of ventilator will actually harm the patient and may lead to the patient's demise. So it's important for us to know how to use the ventilator smartly. All right. So Professor Banguti and I developed this acronym SMART, and we've used it in our different ICU setting. All right. So smart ventilator actually is all about goal-directed ventilation, goal-directed therapy, as it deals with mechanical ventilation. What does that mean? It means that we must be familiar with the patient and the ventilator and take advantage of appropriate or optimal patient ventilator interaction. So the smart ventilation is actually an acronym which means S for setting, M for mode, A for adjuvant, R for release or winning. Then you troubleshoot the ventilator. And that's what we're going to be looking at in the course of our study today. Yes, Solomon Ondudiri, ventilator with VAC and ADPIP. All right, correct. That's for the pulmonary edema parturients patient. All right, so we'll go ahead. All right, so let's look at the ideal characteristics or the characteristics of an ideal ventilator. All right, must be versatile. What it means is that it should be able to ventilate to a tidal volume of 1.5 liters, and it should be able to give a respiratory rate as high as 60 cycles per minute, and should have facilities for different kinds of modes. There it should be economical. All right, you don't want to keep replacing ventilator all the time, and you should be able to nebulize. We had a patient with status asthmaticus, so a ventilator that has mode or facility for nebulization will be very adequate, will be very useful. Inspiratory and airway pressure monitoring. All right, especially in ARDS patient where you don't want to increase the inspiratory or airway pressure. All right, it should be long lasting. It should have alarm systems. All right, disconnect alarms, high pressure alarm, and it should be easy to clean and sterilize. So, characteristics of an ideal ventilator, the mnemonics is to ventilate. All right. All right, so I divided the indications for mechanical ventilation into 4H. All right, by now I'm sure you are used to my mnemonics. 4H. All right, so specific indications, hypoxic respiratory failure. Our first patient in a clinical scenario, community-acquired pneumonia with SpO2 of 85, in severe hypoxemia, PF ratio, very less than 100. All right. So hypoxic respiratory failure. That patient requires ventilatory support. Hypercapnic respiratory failure. Our second patient, the asthmatic patient, had severe hypercapnia. All right. The third one, hypoventilation, when the respiratory is less than 5 cycles per minute, or the patient is unable to get a tidal volume above 5. All right. When the patient is hyperventilating with respiratory rate above 35 cycles per minute, this patient is crying for support because this patient is going to tire out. So basically, there are 4H for indication for mechanical ventilation in the ICU. So let's go straight to our discussion on smart ventilation. So the first thing is setting. All right. What are ventilator settings? These are controls, all right, on the ventilator that you will need to set or adjust in order to determine the amount of ventilatory support that you're giving to your patient. All right. Ventilatory settings should be patient and condition specific for optimal ventilatory output and to improve patient outcome. So each setting that you feed into the ventilator should be patient specific, should be pathology specific, and it should be goal directed. What do I want to achieve? For instance, respiratory rate for patients with normal lung physiology, you want to say that 12 to 14. For patients with obstructive lung disease, like your asthmatic patient that we saw earlier on, you want to give lower, all right? You want to give lower respiratory rate, maybe 6 to 8, all right, to prevent ear trapping. And for patients with restrictive lung disease, like your lung fibrosis, you want to give higher rate. Tidal volume depends also on the patient and pathology, but for all adults with normal lungs, you want to set the tidal volume between 6 to 8. But for patients with ARDS, severe hypoxemia, all right, with very friable lungs, you may want to go as low as 4 to 6 ml per kg. All right, so that is setting for the tidal volume. Flow rate. Another thing we need to set is the flow rate. All right, usually the flow rate in most ventilators is between 40 to 100 liters per minute. What does flow rate mean? It refers to the speed at which your set tidal volume is being delivered to the patient by the ventilator. All right. Now, for patients, COPD patients, you require a higher inspiratory flow rate of up to 90 liters per minute. All right. Why? This allows for longer expiratory time to empty the lungs while you are targeting an IA ratio of 1 to 3. But note that higher expiratory flow rate can cause patient discomfort and may lead to air trapping. So you need to weigh the risk and the benefit. But normally we require higher expiratory flow rate for COPD patients. Conversely, when your flow rate is too low, it may lead to increased work of breathing for the patient. Patient become distressed, and you may have hypoxemia in your hands. The fourth setting you need to set is your fractional inspired concentration of oxygen, your FiO2. Normally in this ventilator, it ranges between 21 to 100%. At the initial initiation of ventilator support, we usually set it at FiO2 of 1, which is 100%. But once the patient stabilizes, you bring your FiO2 down, all right, based on your pulse oximetry readings and your ABG values. Know that the FiO2 should only be as high as necessary to keep the PaO2 in the desired range. I need to say this. A lot of times when a patient desaturates or the patient is hypoxic, maybe on our SpO2 readings or ABG, most people, the first thing to do is to increase FiO2. That is risky, all right? Maybe one of these days when we'll discuss oxygen therapy, I will discuss with you the ills of high FiO2. So keep your FiO2 only as high as necessary, and there are adjuvants, as we're going to see, all right, on how to improve oxygenation without having to increase your FiO2. All right, other settings that must be fed into the ventilator is your inspiratory time. All right, the normal IE ratio, expiration is usually longer than inspiration, but in some settings you may need to increase inspiratory time, such as in ARDS. All right, refractory ARDS, you can do 2-to-1. In fact, in some cases 4-to-1 has been done to improve ventilation. All right, positive end expiratory pressure. Physiological PEEP is about 5 centimeters of water. Only in asthmatic patient, maybe we can allow 3 centimeters of water to also prevent air traveling and auto PEEP. But most of the times for normal lung pathology, we start with a physiological PEEP of 5. All right. So for instance, even in asthma, some people have said that why give PEEP, because they already have auto PEEP. So, but we can give 2 to 3 PEEP. In pulmonary edema ARDS, in ARDS we have given PEEP as high as 15 centimeters of water. So it depends on the patient and the pathology, and that is the essence of smart ventilation in the concept that we're introducing. The other settings that must be fair there is the pressure limit. All right, you must, set your pressure limit for all your patients. All right, the ventilator is not a one cap fits all machine. All right, so pressure limit must be set to protect the patient against viral trauma. And normally your plateau pressure, that is the difference between your peak inspiratory and peak expiratory pressure, should not exceed 35 centimeters of water. A lot of times when the pressure limit is not set, we have had iatrogenic tension pneumothorax in some patients, all right? So it's important, all right? But when you see higher pressure being generated by your ventilator, all right, and that's where troubleshooting comes in, it may just be due to an obstructed airway, which could be due to mucus plug or secretions or kinking of your tube, whether tracheostomy or your endotracheal tube. That's what they call sigh. All right, most modern ventilators do not have this feature, but for academic purpose and historic purpose, I just decided to bring it here. All right, sigh is set in the machine, all right, programmed to deliver an occasional sigh with a larger, tighter volume. All right, this is to prevent development of atelectasis, but it also fraught with concerns of barotrauma and alveolar rupture, which has limited. Colleagues, please, when we are coming in, can we just mute our minds? It's distracting. All right, the other thing we need to set in our ventilator is the trigger. All right, what does a trigger means? It means, all right, what determines the patient's effort to initiate a breath on the ventilator. All right, just like triggering the ventilator. A lot of times the ventilator waits until it's triggered, especially for patients who need just assist ventilation. So it can be pressure or flow trigger. Most times, our pressure triggers are typically set at -2 centimeters of water. All right, but this should be avoided in in the obstructive lung pathologies where you suspect auto-PEEP. In such patients, you want to use flow triggers instead of pressure trigger. And the flow trigger is better for patients who are breathing spontaneously because it also reduces the work of breathing. All right, so this is the summary of settings, and I'm sure by the time you have the slides or when you log into the YouTube channel, you will see more of it here. So we've talked about setting. Now the second thing we need to talk about in smart ventilation is the mode. All right, the mode, SM, mode. What is a ventilator mode? This is what determines how the ventilator supports your patient. All right, and each mode of ventilation is distinguished by how it initiates a breath and how it sustains a breath and how it terminates a breath. When we're talking about cycling, we're talking about changing from inspiration to expiration. So the mode of the ventilator can be distinguished based on these parameters. But note that the best mode that you must employ for your patient is that which provides the maximum therapeutic value with the fewest side effects. So you must know that. And let me quickly say this, in modern machines, there are different modes that have been introduced, all right, that is quite different from the traditional modes that we know. But I'll try my best to discuss some of these things with you in this tutorial. All right, so modes of ventilation can be classified basically into two. We have the assist and the controlled modes. All right, the assist mechanical ventilation of the mode is what we use most of the time in the ICU because of its advantages. One, it is designed to work with the patient's own respiratory effort. And number two, what it does is that the ventilator detects the patient's respiratory effort, and the ventilator is triggered to boost the respiratory rate. So throughout the breathing, the work of breathing, the patient is participating. And we're going to be looking at some of the advantages because it prevents respiratory muscle atrophy. It reduces the tendency to mechanical ventilator dependence. So that's why we use most of the time assist mode ventilation in the ICU. All right, the second one is the controlled mode ventilation. All right, here, most of the times, most of us are anesthetists, this is the mode we use in the operating room in our theater, where the ventilator completely takes over the patient's what was this? Okay, while the ventilator completely takes over the patient's ventilatory requirements. In this mode, the patient cannot generate spontaneous breaths or volumes or flow rate. All right, and controlled mode can either be volume controlled or pressure controlled. In some cases, we employ this mode in the ICU for patients we are having difficulty, all right, synchronizing with the vent. Our patient is balking and fighting the ventilator, colloquially speaking. Patients with tetanus, all right, that every little noise, every little light can trigger spasm. Patients with status epilepticus, convulsive disorders, or patient with cross chest injury. These patients, you may want to completely control their ventilation. But there are a lot of disadvantages. Patient ventilator asynchrony, the risk of barotrauma, hemodynamic compromise, ventilation perfusion mismatch, and most of the times because the patient is not using their respiratory muscle, they are most likely going to be ventilator dependent. All right, so we're talking about controlled mode ventilation, and you're going to see the graphical representation on the right side of the screen. All right, so when we talk about control, volume control, control mechanical ventilation, you set the tidal volume that you want to be delivered to this patient at a specific respiratory rate. Now, the set values are independent or irrespective of the patient's respiratory effort. If you can see it here, all these are mechanical breaks. These are ventilator breaks. These are ventilator breaks. In between these ventilator breaks, there are no spontaneous effort from the patient. All right. So in between ventilator deliver breath, the inspiratory valve is closed. So this patient is not allowed to take any inspiratory effort. All right. The peak inspiratory pressure that is developed now depends on the patient's lung compliance and airway resistance. And like we said, this patient, due to barotrauma, volume trauma, we know as the ventilator-induced lung injuries. And most of the time, these patients are prone to develop pneumothorax or tension pneumothoraces. All right, the other one is the pressure controlled CMV. All right, here what we set is the pressure. All right, the ventilator delivers a pressure limited. You're telling the ventilator, don't go above this pressure. Maybe for instance, 25 or 30 centimeters of water. All right, so no matter the tidal volume that is delivered, do not go beyond it. So the peak airway pressure and alveolar airway pressure is the controlled here. All right, but the tidal volume, the minute volume, alveolar pressure depends on the lung compliance. For COPD that have very high lung compliance, all right, so the pressure that is needed will be low. For patients that have low compliance, the pressure that is needed to change the tidal volume to achieve tidal volume may be higher. So the peak airway pressure or the alveolar pressure in this patient, all right, is what is controlled, but the tidal volume and every other parameters depends on the lung compliance and the respiratory rate here. What we do in this group or in this ventilatory mode is that we sometimes change the inspiratory pressure, all right, to achieve tidal volume. Sometimes if you want to achieve a tidal volume of 350, 400, but you put the patient on pressure control and you're getting maybe 250, less than what you want, you can increase the peak inspiratory pressure or the inspiratory pressure to achieve that. But this ventilator cannot develop any pressure above the limit that you have set it, and that is the advantage here as it protects against barotrauma. But look at it here. If you look at the flow pattern on the right side, all right, you'll see that it gives a decelerating flow pattern. All right, and this is characteristics of pressure controlled ventilation. All right, they give a decelerating, all right, the flow reaches a peak and it comes down gradually while the pressure remains constant. All right, and this is characteristic of pressure controlled ventilation. All right, so the advantages of pressure controlled CMV: less peak airway pressure, so reduces the chances of barotrauma, and obviously, importantly, reduces the risk of hemodynamic disturbances. It allows equal distribution of gases in the alveoli, and the compensation for loss of ventilation is better. All right, now like we mentioned before, tidal volume can be reduced if the lung compliance, or if there's reduced lung compliance, or there's increased airway pressure or airway resistance. All right, the tidal volume may be low, and that's why you need to do your troubleshooting to be able to know what to do to increase your desired tidal volume. Patient ventilator asynchrony is one of its disadvantages, and it can also precipitate ventilation perfusion mismatch. Yes, so this is our darling in ICU, the assist control mode ventilation. All right, and you can see on the right side of the screen, you see that this is different from the mode we saw before, the volume or the pressure controlled CMV. In ventilator assist control mode, the ventilator assists the patient's initiated breath. Now let's get this. If you look at this, this is negative pressure on the right side. So the patient makes an inspiratory effort and triggers the ventilator. The ventilator detects that this patient is trying to make some breath and assist it, boost the ventilation. Guy, this is not fair. I'm being distracted with all these guys that are just coming in and not muting their mics. All right, so the ventilator detects the attempt of the patient to take a breath and boost that respiratory pressure here. All right, so but if the ventilator waits and the patient does not does not initiate any breath, the ventilator goes ahead and delivers the tidal volume that has been set at the set respiratory rate. So altogether, the ventilator does its job, but it waits for the patient to initiate a breath. And if the patient does not initiate a breath, the ventilator goes ahead to deliver the tidal volume and the respiratory rate that you have set. All right, like I said, mandatory mechanical breath may be either patient triggered or time triggered. All right, the patient. So if we say that if the patient is able to develop or to generate -2 centimeter of water of pressure, the ventilator, that is the triggering we're talking about. We set the trigger, the patient is able to generate -2 centimeter of pressure of water, the ventilator boosts it. But if that does not work, we wait for maybe 1 to 2 seconds or 1.5 seconds. If the patient does not initiate any breath within that time, all right, the ventilator goes ahead to deliver it. Now listen, if the respiratory rate is less than the preset rate, the ventilator will assist. All right, if the respiratory rate, if the patient, for instance, the patient, you said the respiratory rate about let's say 14, and the patient is unable to get up to 15, that 14 that you have said, the ventilator will assist. Maybe the respiratory rate patient is able to make a respiratory rate of 8 out of 14. The ventilator will go ahead and assist and boost it up. But if the patient is able to generate that respiratory rate, the ventilator just accompanies and boosts the patient's respiratory effort. I hope note your questions. If you have questions, we can discuss it as we go toward the end. So the advantages of assist control mode: it reduces patient's work of breathing, enhances better patient ventilator synchrony, produces less VQ mismatch, all right, prevents the use atrophy of not just diaphragmatic muscles or your respiratory muscles. Now, but disadvantages: you can have alveolar hyperventilation because you are combining the patient's inspiratory effort and the ventilator triggered breaths. For patients in obstruction, especially in COPD asthmatic patient, you can have high intrinsic PEEP, all right? And all of this will lead to increased mean airway pressure, which can also cause hemodynamic compromise. All right, so there are different types of assist control that we are used to. We have the intermittent mandatory ventilation. If you look at the graph on the right side, you will see here that these broken lines, patients, respiratory effort. All right, so what the ventilator does is that the ventilator delivers preset number of time cycled mandatory breath. These unbroken lines are ventilator delivered breaths. All right, so in between patient spontaneous, this broken line patient spontaneous breath, the ventilator delivers it. But the problem here is that it's not synchronized. All right, look at it here. This one is not synchronized. So this is the problem with intermittent mandatory ventilation. And this used to be one of the oldest assist control mode of ventilation. You can imagine the disadvantage. There will be breath stacking upon one another, and this will lead to increased lung volume and pressure, which can predispose the patient to barotrauma. Now, because of that, we have what they call mandatory minute ventilation. All right, this is similar to your IMV, the intermittent mandatory ventilation, but instead of setting the respiratory rate, you set the minute volume, which is the tidal volume times your respiratory rate. The ventilator measures the minute volume of the patient, and if it's less than what he has calculated, it switches to mandatory minute volume. All right, and the ventilator delivers that volume. All right, what happens is that this is suitable for patients with variable respiratory drive. All right, they are able to meet their bulk flow, and at some time, at other times, they are unable. So the minute volume is what the ventilator calculates and delivers when the patient fails to generate such breath spontaneously. All right, improvement upon the IMV is when we have the synchronized. If you look at it from here, the graph, these are patients spontaneously generated breaths, all right, which are synchronized with the ventilator delivered breaths. So it becomes a continuum, all right. If you look at it, it becomes a continuum, and all the breaths are synchronized. All right. So the ventilator delivers assisted breaths to the patient at the beginning, as the patient is making that flow triggered or time triggered breaths. All right, but there's what we call the synchronization window. This is the time, this is synchronization window here. I don't know if you can see my arrow. The time between the patient, generated spontaneous breath, and the time the ventilator detects that breath and assists the patient is what we call the synchronization window. Now, it avoids breath stacking because all of them, becomes a delivered breath. All right, it's a continuum, so there is no breath stacking. And in between, if you see this, in between mandatory breath 1, mandatory breath 2, the patient is allowed to take spontaneous breathing. All right, so what happens is that the patient, all right, takes part of his respiratory effort throughout and prevents disuse atrophy of respiratory muscles. And that is why a lot of people favor SIMV. All right, so the advantages here is that it maintains respiratory muscle strength because the patient, in between mandatory breath that the ventilator is delivering, the patient is breathing, avoids disuse atrophy, reduces mean airway pressure. It also facilitates weaning. All right, but disadvantages there is that most of the clinicians are sometimes may want to wean the patient quickly off the ventilator, all right, and you may have respiratory muscle fatigue and failure to wean. You put the patient back on ventilator. All right, I won't talk about PEEP here. We'll talk about this one later. So the other one is the pressure support ventilation. Most of the times, pressure support ventilation is used as a weaning mode, but sometimes we can use it with SIMV volume control. Here, every inspiratory effort that this patient makes is augmented by the ventilator at a preset level of inspiratory pressure. All right. So what happens is that during the plateau, I told you the plateau pressure is the pressure between peak inspiratory and peak expiratory. So what the ventilator does is that it adds pressure, applies pressure, all right, to the plateau pressure during spontaneous breathing. So it assists the patient. The bulk of the work is not left for the patient alone to do. In between this, all right, the ventilator delivers some pressure support. Now it can be used in conjunction with spontaneously breathing patient in any mode. All right, so for here now we have SIMV volume control with pressure support. Just apply some pressure to overcome. Sometimes the patient may be breathing well but is unable to overcome the pressure imposed by your tubes, your endotracheal tube, your tracheostomy tube, even by your the circuit system, the connecting valves, all right, your humidifier that are all connected to the patient. So the ventilator helps and delivers additional pressure for the patient to be able to overcome the resistance that all these adjuvants of your ventilator is posing to the patient. All right, adaptive support ventilation. Most of these modes, I've used them before. They are very wonderful. And adaptive support ventilation, what you do, you feed the patient's data into the ventilator. For instance, the patient's body weight, the percentage meaning volume of this patient that you've calculated, you feed it into the patient, and the patient has predetermined setting of almost 100 liters per kg per minute. So once you feed the patient's data into the ventilator now decides and selects the required frequency, inspiratory time, your IE ratio, and the pressure limit for mandatory and spontaneous breath. All right, this is beautiful because the bulk of the work is taken over by your device, your mechanical ventilator. All you need to do is to say patient AS, body weight 65 kg. I want the patient to have so percentage of minute volume that I want the ventilator to deliver. You feed that into the ventilator, and the ventilator, using his computer, all right, selects the frequency, the inspiratory time, and all the parameters that is required to meet the ventilatory requirements of the patient. So this is what we call the adaptive support ventilation. Proportional assisted ventilation is another type of assist control mode ventilation. All right. Now, the ventilator offers assistance to the patient in proportion to the patient's effort. All right. So if the patient is making like 20% of the inspiratory effort, the ventilator will provide the 80%. Now, if the patient is recovering and the patient is able to provide 80%, the ventilatory requirement will now reduce to 20%. So it instantly measures the flow and volume that the patient is pulling in and calculates the compliance and resistance of the respiratory system to determine how much pressure is needed for each breath. I hope you understand that. This is beautiful because the ventilator just sees, waits for the patient, how much effort is this patient is making. Now this patient is in respiratory distress, is making only 40%. The ventilator calculates, so it requires 60%, and the ventilator delivers that 60%. It's indicated for patient with spontaneously breathing, patient with interrespiratory drive. Why? Because the ventilator is going to calculate the percentage, the proportion that the patient is bringing in. It's just like when you say, what are you bringing to the table? The ventilator says, hey guy, I'm asked to help you, but what are you bringing to the table? All right. And the patient says, okay, you are bringing only 40, no problem, I'll give you the remaining 60. You are bringing 20, I'll give you the remaining 80. All right, volume assured pressure support. Let me look at the time. We have a lot to do. Oh my God, we're still on mode. All right, we have volume assured pressure support. This incorporates respiratory pressure support ventilation. All right, maybe I should just run over this. You can read this up. All right, I must say something about this pressure regulated volume control. Beautiful, mode of ventilation. Now, the idea is you want to keep your peak inspiratory pressure to the lowest possible level. All right. Now, this is designed to avoid barrel and volume trauma because you achieve your volume support while you are keeping your peak inspiratory pressure to the lowest level. How does it do that? It alters your peak inspiratory time in response to changing airway and compliance characteristics. All right. If the compliance is low, all right, it alters the peak pressure. All right, this guy requires more pressure because the lung compliance is low. All right, and as the air compliance reduces or changes, the ventilator regulates it. But at constant flow, the peak inspiratory pressure increases with increased airway resistance. Like I mentioned, all right, there's airway resistance, and needs more pressure here. To compensate for lower flow, inspiratory time is prolonged. All right, so pressure regulated is a very Will you please share the slides for me at the end? Thank you, Dr. Diribia. All right, it's always on the group. If you're on the group, the lecture slides are there. If you're in the tutorial group, the WhatsApp group. Okay, so much. Airway pressure release ventilation. This is similar to your CPAP, all right? Airway pressure is maintained at moderately high levels throughout most of the respiratory cycle, but there are brief periods where the pressure is reduced to allow for adequate lung deflation. All right, the airway pressure initially is high, but the ventilator allows for brief periods of low pressure to allow for lung deflation. Increased pressure ensures alveolar recruitment and oxygenation, and a brief deflation period allows for CO2 to be exhaled. All right, this is indicated as an alternative to your conventional volume control ventilation for patients with reduced lung compliance. All right, because it allows brief periods of low pressure to allow for exhalation of carbon dioxide. Oh my God, I need to. It seems as if each of the mode is interesting to me. People that are saying, please, you need the slide. It will be provided on the group. All right. If you are not on the group, meet your country rep to add you. All right. I can't send slides to individuals. Thank you. All right, so the neurally adjusted ventilator assist mode, this is beautiful. All right, what you do, if you look at it here, all right, there you put an esophageal catheter, all right, with an electrode. All right, what it does is that it picks the electrical activities of the patient's diaphragm, all right, in order to determine the patient's respiratory effort and to assist it. So it's a proportional ventilatory mode that uses electrical activity of the diaphragm to offer ventilatory assistance in proportion to the patient's effort. So this esophageal catheter has an electrode, all right, that captures the electric signal from the patient's respiratory center, activating the diaphragm using the ET catheter, like we said. In contrast to all other forms of ventilation, which adopt the conventional pneumatic signals, this neurally adjusted ventilator assist mode uses the respiratory center. All right. So with this mode, the patient retains full control of his breathing pattern. It improves patient ventilator asynchrony, reduces the risk of over assistance, and this is what we most of the times we are guilty of. We over assist the patient, but this mode prevents that. All right. Okay, so this is smart ventilation mode, and what's the time now? Oh, we are past the hour mark, and we still have a lot to talk about. Okay, I think we should stop here, and we'll continue with the A. And the A of smart ventilation is adjuvants. All right, and we're going to be, what are adjuvants? These are other things you can impute in your ventilator to get your desired good directed ventilatory needs. All right, I can't do this in 5 minutes because I don't want to rush it. Okay, so do we agree we postpone? Let's end the lecture here and we postpone.
Yes, sir, we can postpone.
Yeah, any question, any comments? Let's just quickly discuss. We can go back to our clinical scenario, but any question thus far or contributions? All right, somebody said, good evening, sir. Thank you so much for your efforts, sir. Is APRV same as BIPA? No. BIPA is a form of non-invasive ventilation, all right? No. Any question, any contribution? Abdul Rashid Lawa, how are you, sir? Any question? Dr. Amphosinia. Where are my people? Dr. Amphosinia, say some Amani Philemon. Hello, where's everybody?
Good evening, Prof.
Yeah, you people should not go quiet on me. It's as if you'll be sleeping throughout all my lecture. Are you sleeping? You people should say something. Amphosinia.
We are with you, Prof, sir.
Sure, say something. Dr. Amphosina, yes, you are back here.
Yes, I'm back.
Say something.
Unfortunately, I joined in a bit late. I joined in while you're already on the mode. So,
Oh, okay.
yeah, it's
Say
difficult
something
for me
about
to
the
comment.
mode. You are from Malawi, I guess.
Yes, from Malawi.
Yes, say something about the mode. Don't worry, I'm putting you under pressure. Don't worry, I'm just pulling your legs. Anybody?
All right.
You know, a teacher wants to get feedback from the students. Say something to me, guys.
Definitely. For me, I can put in a comment.
Yeah, please go ahead.
Just to say that I haven't seen all the modes being discussed. I joined in late, as I said, but I think even for the ones that I've joined in, I've listened to, I think I've learned a lot because I've seen the modes on the ventilators, some of which I've never used. But now I think after this lesson, I think I can be a bit more confident using some of the modes on the patient.
Please. Like we said, the ventilator is a life-saving device if we use it smartly. And the idea of this presentation is I want us to use, just like our smartphones, our smartwatches, let's use our ventilator as a smart machine. There's a lot we can achieve if we use our ventilator smartly. Thank you, Dr. Alfosini. Any other person? Dr. Irene. Okay, somebody is raising his hand. This is an old hand or please, somebody is raising hand, old hands or new hand. John Claude, yes, John Claude, my brother from Rwanda here. Say something.
Yes, for what I can add, for patients who are on assist control, and also they have two types of breath. There is a mandatory and assisted breath, and for the patients who are on SIM, they have three types of breath. That's mandatory breath, assisted, and spontaneous breath. So you have to say that, and to have to ensure that the patient can be weaned early from the ventilator to prevent the ventilator-associated pneumonia. And also we have also to set the patients on ventilator basing on the ideal body weight rather than basing on the actual weight of the patient. Thank you very much.
Thank you, John Claude. Habu Mugisha. All right. Atala should be from Tanzania. Am I correct? Dr. Aniti Ebu, where are you guys?
Hello, I have a question.
Yes, please go ahead. Thank you.
Yes,
Maria
about the neuro.
Mangada from Malawi.
Yeah, about the neuro mode. Is there is there a specific ventilator that allows that mode? Because as far as I can remember, I've never seen that mode in the ventilators that we use. Or is
Sorry,
it that
come again. I didn't hear you.
Yeah, are there specific ventilators for the neuro mode, more ventilatory mode? Because I've never seen that mode in the ventilators that we're using.
Yeah, most of the time, the modes, it depends. we do actually when I get to a new place is to look at the ventilator that is available and look at the different modes that are there. The modes, all the modes that we mentioned are not necessarily a one ventilator. All right, all of them are not in one ventilator. It's just like your Apple Watches, your other stuff. But the important thing is to look at your ventilator that you're using and look at the modes that are available on that ventilator. And also for administrators, it's good for us to know the kind of modes that we normally will employ for our teeming population of patients so that we can advise management accordingly so that they can give us the ventilator with the modes that we desire. But all the modes that I mentioned here definitely are not all present in a single ventilator. Does that
All
answer
right.
your
Thank
question,
you.
Maria, doctor?
Yes, it does. Thank you.
All right. Okay, I think if there are no other questions, we should call it an evening. Unfortunately, I thought we could do quite a lot, but I think we spent time talking about the the clinical scenario. What I should do, let's go to the clinical scenario. Okay. What stage of ventilation is it ideal to practice protective lung ventilation? Patients, ARDS patients, patients with fibroid lungs, these are patients you want to do lung protective. And lung protective is actually to protect against barotrauma and volume trauma. And you have to do is you have to reduce your tidal volume, all right, so as much as low as sometimes 4 mil per kg, ideal body weight or lean body weight, as Dr. John Claude mentioned. Okay, group link for those asking for the slides. Dr. Faustina, I don't understand that. What do you mean by group link?
No, I forwarded the group link
Oh,
above.
you forwarded it. Okay, thanks.
Yes.
Okay. Prof, how common is naval mode used in Africa? I don't know. I've not been around Africa. I've just been but it's a very good mode that we can use. If, like I said, the answer to a question Dr. Maria asked, it just be familiar with the different modes that are available in your setting, in your ventilator. All right. Don't just do SIMV. Just look at the different modes that are available in your ventilator and use them. What we are promoting is goal-directed ventilation. All right, and that's why we come up with the idea of smart ventilation. You won't see it in any books. It's just an idea that we said, okay, the ventilator can be used smartly. How do we do goal-directed ventilation? Thank you. I hope I'm able to respond to everything that has been said here. I'm also interested in knowing how to detect auto PEEP, sir. Auto PEEP. Most of the times, auto PEEP is due to obstructed airway. All right. After inspiration is an active process, expiration is passive. So there's reduced pressure to overcome the airway that is obstructed, especially in obstructive lung disease, like your asthma, COPD. So when you have auto PEEP, one of the things you'll see that your peak airway pressure or your peak airway pressure or peak inspiratory pressure will also be high. All right, and this can also lead to barotrauma. Sometimes you can have pneumothorax in your hand. But what you need to do is look at the patient's pathology. Is this patient likely to have auto PEEP? So for those patients, it's actually a preventive thing rather than trying to react to auto PEEP. But what you need to do is to ensure that you look at your peak inspiratory pressure, peak airway pressure, and if your ventilator can measure peak alveoli pressure, all these things will be higher than the set value. And most ventilators that have alarm, they will have high pressure alarm system. When those high pressure alarm system goes on, you want to look at is there increased peak airway pressure or peak inspiratory pressure. And when you look at it and you have ruled out other causes, There are no secretions, there are no mucus plug, your tubes are not kinked. Most likely the patients have an auto PEEP. I don't know if that helped your question. All right, there are a lot of questions here. Thank you, sir. When reducing FiO2, what is the time interval and how much is it supposed to be? Is that to be? To reduce per time? Yes, the FiO2, like I teach people before you start a patient of mechanical ventilation, it's always good to have your baseline ABG values. All right, baseline ABG values, more especially when it has to do with FiO2, look at the baseline PaO2. Then you want to achieve, so for instance, let's say your PaO2 is at 80, like the patient we had before, and you want to get PaO2 about 240. So once you start your FiO2 of 100, and you after, normally I repeat ABG 2 to 4 hours after initiating mechanical ventilator. When I see that I'm getting higher PaO2 close to 240, 200, I'm reducing my FiO2. All right, I go gradually from 100, I go to 80. All right, the next day when I get it and my PaO2 is still high with my SpO2, I gradually go back to 60. By the time I'm getting PaO2 of 240 for that particular patient, SpO2 greater than 95, I come to 40. The FiO2 that is required is what will achieve SpO2 of greater than 95 or PaO2 of greater than 100. Does that answer your question, Dr. Rayanu Yusuf Jasawa? All right. Good evening, Prof. How do we manage increased auto PEEP? You reduce your PEEP. You reduce your PEEP, all right, and you increase your flow rate. All right, you increase your PEEP, increase your flow rate, and you increase your IE ratio. All right, if your IE ratio is 1 to 2, you can increase to 1 to 3 or 1 to 4, as the case may be. All right, I think I've answered all questions. I tried to answer all questions. What's PMOS? What is that? Stanley iPhone. I don't get your question. What is PMOS? What's that? Can you just unmute and talk to me? Because I don't know what PMOS is. Unmute and ask your question. It's easier to track questions like that, because going through the chat, I may miss some. Be bold. Ask your question, guys.
Sorry, Prof. Good evening. I think it's with regard to the flow and the pressure waveform of the modes, the ventilatory modes. I've listened to somebody explain it, but I didn't really get it. I think it has to do with the effort the patient makes during the ventilatory cycle, how you could determine it on the ventilator, but I didn't really get it. So I thought you could have an idea. That's why I asked.
Did I mention it in this presentation?
No, it wasn't mentioned.
Okay, because let me see if I get you. Let's go to where I mentioned the flow decelerative pattern of your pressure control. Is that what you're talking about? Stanley?
I'm here. Okay.
I'm trying to go back to, where is it? Not here.
Yes. No. Okay. No.
Here.
Yes. So I think this is the diagram that they use to explain that. But I don't really I think it has to do with pressure control. Yeah, this is pressure control.
This is pressure
Uh,
controlled, all right? This is actually pressure controlled mode ventilation. So what you said is you set your is pressure limit. I don't want, no matter what, no matter the compliance of the lung, no matter the resistance of the airway, don't go beyond this pressure. This is the square form you are seeing here. You have your pressure, you limit the pressure that the ventilator can deliver. This is the pressure time curve. But if you look at the flow time curve, it gives you a decelerating pattern. All right. So the flow at the initial, when you get your peak pressure, maybe let's say 35 centimeter of water, during the plateau period, all right, during the plateau period, the flow decelerate, comes down, so that the idea is also to reduce volume trauma. So you have a flow deceleratory pattern. I don't know if that explains what the question you're asking, because the PMOS maybe is an abbreviation, that is it the pressure of the muscle or the respiratory muscle of the
yes,
patient?
yes, something like I think it's I don't know if the terminology this respiratory physicians use. I think it was a respiratory respiratory therapy. Sorry. Yeah.
Yes, they have their own terminologies, but we don't have respiratory therapists. I don't actually use them, but it looks like the pressure that is generated by the respiratory muscles. That's what it seems to me, the PMOS here. All right. But here in pressure control, it doesn't come to play because the breath is totally controlled. The patient is not allowed to make any spontaneous breath. So the patient cannot generate intrinsic pressure by his respiratory muscle. Do you understand the point I'm looking at?
Yes, sir.
Pressure controlled mode, pressure control CNV mode, the total breath that is being delivered to the patient is all ventilator generated. So there's no amount of pressure, there's no pressure being generated by the respiratory muscles of this patient.
Thank you.
You're welcome. You guys just unmute somebody, Akere David. Please, how do we determine percentage minute ventilation? You calculate the minute ventilation of your patient, which is your tidal volume times respiratory rate. So you want to say this patient may not be able to generate more than 20. I mentioned it during the adaptive support ventilation. Maybe the patient is able to generate only 40% of the minute volume. You calculate there, say, okay, this patient is able to generate only 40%, so the ventilator provides the remaining 60%. David, did that help? All
Hello,
right.
Prof. Thank you, sir, Prof.
Did that help?
Prof, I
Yeah,
wanted to ask a question, sir.
please go ahead.
Please, what is the difference between the mode of action of assist control ventilation and the SIMV?
SIV is a type of assist control. Basically, the mode of ventilation is divided into two: assist control and controlled ventilation. So all the other ones I've mentioned, SIMV, intermittent mandatory ventilation, adaptive control, your pressure regulated volume control, all those ones are under assist control ventilation. Did you get that, Andrew?
Yes, Prof. Thank you, sir.
All right. I really wish we could really talk more about ventilation. It's my passion. Mechanical ventilation is really one of my passion in ICU because it can help rescue quite a number of patients. And if it's not done properly, it can actually kill the patient. What is meant to save the patient can kill the patient. All right, I think we should call it an evening, and next week we will continue with smart ventilation. Actually, this course is I divided into 5 modules. So I was being ambitious to see if I can finish it in 1 hour. This mechanical ventilation is actually divided into 5 modules. Smart ventilation 101, 202, 303, 404, and 505. So if you want a detailed thing, you can tell your institution to invite me, and we'll do a 1 week long tutorial demonstration of mechanical ventilation. All right, and for senior, invite me to Malawi. Let me come and do this there. Amani Philemon, you want to say something? You unmuted your mic.
I just wanted to welcome you to Tanzania.
Why are you exposing me to everybody here? I'm looking forward to it, my brother. Thank you so much.
Thank you.
All right, do have a wonderful day, everybody. We'll see you next week. Let's make it a date as we continue smart ventilation tutorial. Good night. Thank you.
Good night, Prof. Thank you very much.